Thank you, everybody, for your kind attention. Hey, how are you guys? Hey, guys. This is my family here. That's my sister, Maggie. She works here at the Mint. Hey, Maggie. You missed Jack came in before. And then those two young men in the blazers there, that's my nephew, Josh Bergen, soon-to-be law school graduate, right? Congrats. Ricky's at High Point, hopefully going to dental school. And our daughter, Mary, snuck in before, so way back. So we got a whole family here. So I appreciate that. In fact, Maggie is our connection here. So as much as we all appreciate this venue, it started through association with my lovely sister. So I had the good fortune of practicing with a great group here in Charlotte. We lived here since 2012. This is a little bit about our family here. Had our kids in 2 sets, which nobody recommends, but the older 3, and then a long break, and then this little criminal came along about 2 years ago and mixed everything up, but she's amazing. So notice she's not here today. But anyway, I also have the good fortune to practice in a big group. So this is big and growing. We try to be everybody's kind of hometown oral surgery practice. So even though we have a lot of pins on the map, we try to stick to one office and just cover what you all are going to need. Yeah, we're doing great. Drop this one. Thank you. What y'all are going to need and not move around a lot. But given that we have that size of the group, it gives us the ability to kind of spend some time in subspecialty areas. And my favorite is cleft and craniofacial. This is just a snippet of our cleft team. But if you are or have ever volunteered on our team here, Asheville, Greenville, raise your hand. There we go. A lot of people that were here this morning and left. So thank you very much. This is a powerful group, community-based. No one's employed by the clinic. Everybody's coming, taking time out of their practices, their lives to be a part of it. So I appreciate that from the bottom of my heart. Thank you. So when it comes to growth and development, I think it's kind of interesting to look at the growth and development of the human skull because it has implications on airway, right? We think of things that grow as sort of becoming bigger versions of how they start out, but it's really not true. You see this differential growth in the development of the human skull, and you can see this ratio shift from 8-to-1 heavy in the cranium, and so we kind of grow into our skulls, right? And along with that, we grow and we ideally develop proper airway. This curve illustrates from 0 to the proverbial 18, and you see this rapid growth of the cranium, takes off and then levels off. Maxilla follows somewhat of a similar curve, and then the mandible, which obviously has implications on airway and breathing, picks up the trail. And this is kind of a smoothed out curve when you look at individual gender growth issues. And so this one kind of illustrates it in kind of cartoon form between the male and female. We're starting to see some differences in growth of the maxilla versus the mandible at different age points. Females developing first physically earlier than males. Some people think socially as well. It's probably true. I have both, so that's how I know. And here we look at it classified by gender as well. And then you look at the average age of maturity, 16 in males, but 14 in females for the maxilla. And then you look at mandible, and we see 14 to 16, so slightly older, like the curve suggested, in females and in males beyond that, right? So we're already looking at 2 layers when we talk about growth and development that affects the airway. As we started, somebody said, Dr. Trey said before, peeling back the onion, right? One layer is, are we talking about the maxilla or the mandible? Second layer is this a male or female, right? Those are different answers depending on what point in time you select and when you want to intervene. With the maxilla, we see kind of this appositional down and forward growth of the maxilla at about 51 degrees from the horizontal plane. But the mandible, part of the reason that that curve is choppy and not smooth is because there are different growth centers. So if you look at the growth, the condyle leads the way, so there's more growth there. So that really is the powerhouse of growth, more so than the ramus, then the alveolus, and the alveolus over chin. So not the same in terms of growth centers, not the same in terms of years that those centers grow. So now we are, male or female, maxilla or mandible, which part of the bone are you talking about, right? So it can be that nuanced when we're talking about growth and development. I think it's interesting that if you're nerdy and you remember back, I'm sorry our PhD, Dr. Singh isn't here, but your appositional or your bone development from endochondral to intramembranous, the endochondral growth is right here. That's it for the whole skull, the condyles, and they lead the way in terms of growth and development. So when we look at data on this. We see this is mid-face, so think, in a male. So this is the triangle is, think of it as maxilla, kind of smooth, matches overall lower facial height growth, okay? And you see the seesaw nature of the mandible, okay, in the male. Got it doubled up there. So we look at the same issues with females. Again, triangle graph, lower facial height, all matched, nice and linear, little seesaw, not as much as the male, but still the case in the female. So you overlay them. I know this is kind of dizzying, but this is male and female mandibular growth over male and female maxillary growth. And you see at whatever time point you pick, the rate of growth is speeding up, stopping, speeding up, stopping. So when it comes to that, I think we need to keep in mind that that's the case. Now, what about other factors? What about ethnicity? Well, some really interesting data was done that shows that that's not the same, okay? So when they looked at 4 groups, Caucasian, Hispanic, Asian, and Black, fairly consistent data between the chronologic age, CA, and the skeletal age, right? How old a patient is as far as their birthday, how old are they really biologically? And you see there's some consistency here, except in the Asian population. We see a pretty broad disparity as much as 2 to 2.5 years, okay? There's another layer, right? Which bone are you talking about? Male or female? Maxilla or mandible? Which part of those? And then what is the ethnicity of the patient? So very, very nuanced, as we say. So what does that have to do with our pediatric airway assessment? Well, it means that if we have an intervention that has to be done as neonates for survival, we do it. We would love to not have to do it, but we have to do it, and we'll look at that case. But then there are situations where this came up earlier in both Ryan and Alex's presentation when it talked about at different age groups, maybe you bring in these providers, maybe you bring in those providers. It also relates to the time and pace with which we treat cleft and craniofacial patients. Surgery is very episodic. Not everybody knows this. There's about 5 surgeries from birth to 18. We have the ability to do them all at once, and we dose them out. We dose it for growth and development reasons. So that's the tie-in here. But if we just look at the various aspects of the airway, since this is the focus today, we can see that there's nasopharyngeal, nasal cavity. We talked about that relative to maxillary transverse discrepancies and correction. Nasopharyngeal and retropalatal, a little bit more the domain of our Lafort 1 osteotomies. That's late in teenage years. But this is the one that is life-threatening, right? Both in terms of sleep disorder breathing, but upstream of that, sometimes just airway occlusion based on growth anomaly. And the real challenge in this whole airway discussion is this formula right here. And I am many, many years away from my physics minor in college, but what I do remember is that when you narrow the lumen of any airway, you increase their air resistance by the power of 4. So it doesn't take much of a change in the air passage volume of, in this case, a human or human child to dramatically increase the resistance. So the opposite is true. If you're a glass half full person, it doesn't take much correction of it to decrease that resistance and provide a lot of relief. Because, and I love where's Nikki in her talk, if you can't breathe, nothing else matters. I love that. Upper airway obstruction, again, not upper like palate, upper meaning above the larynx. Fairly common, as much as 10% of our children affected by that. And we know that, as we talked about today, what some of those consistencies are. Just to take a brief half a step back, some of our analysis needs to be, is this an actual respiratory problem or is it a central nervous system problem? So we haven't touched on it yet. It's probably a whole separate topic, but there is such a thing as what we call central sleep apnea. The respiratory apparatus is working properly, the brain's not sending the signal, or the signal's not being sent or received to generate that inspirational cycle. So we have to be aware of that. So this is kind of what we, in our world of cleft and craniofacial, when we're dealing with the early on, pretty critical airway impingement cases, this is part of our wheel of what we look at here. We look at trends, and that's the thing. Neonates have this ability to almost sort of store up oxygen, and they'll give you the false idea, if you observe them, that they keep an average SpO2 pulse oximetry rating that looks pretty impressive. It looks safe. But then they have these profound, if you dig into it, like if you go into EPIC, you go into their chart and you look at the trends, you see these profound desaturations, and then they speed back up and make up for it. And then they hover there and they sustain, spit by that oxygen dissociation curve, but they can hang out there for longer than an adult. And then they crash and they speed back up. So it's not really, in those cases, the average SpO2 that we look at. If they call us and go to the NICU, for example, about a child that's retrognathic in the mandible is having trouble breathing, we have to zoom out and look at the trends and what's their retained carbon dioxide and get some labs, because they can have a hidden respiratory acidosis from that retained hypercarbia, but their average SpO2 looks good. And it might look good when you're there, crib side. So you really have to zoom out with these kids, even though it's acute, and take a zoomed out look at what they're doing overall metabolically. Because it also doesn't take much for them to kind of fall off the curve metabolically. It's a big labor, metabolically speaking, for these little infants that have these compromised airways to try and maintain it without help. And I like to remember this too, and this was well covered, and importantly so, the wheel between infant feeding and the interplay in airway. Because infants have an ability to sort of breathe while they feed. I sometimes think my teenage boys do too. But we lose that as adults, and so as they grow and get older, it becomes more separate. There's supposed to be a handoff, but some kids aren't able to make the handoff. So feeding issues can be a tip-off to speech, breathing airway issues, and airway can be a tip-off to feeding. Did I get that right, ladies? Sound good? Okay, excellent. So this is one of the ways that we non-invasively test. This is what it looks like for a baby to have a sleep study. And this polysomnography is really important to come up with, just like in an adult, what are we dealing with from an AHA or apnea-hypopnea index. Same thing they measure in adults. How often in the course of one sleep cycle are they apneic? How long do they go without breathing at all? What's that ratio? What are the events? And it measures all this, but as was discussed before, and I think Ryan brought this up when he talked about nocturnal enuresis, there's a connection there. So again, zoom out, ask the questions, have it on your form, but what do we do about it? So I'm going to move into my favorite part, and I'm trying to make up time in flight here, so I'm purposely going quick. But what do we do? Surgical side of things, like, oh, I got an idea. We can operate, we can do something. And it's not always the case, but often that's what it comes to. This is one that we talked about as before, but very, very often that retropalatal compromise from adenoid hypertrophy and tonsillar hypertrophy is a big deal. We get this wave of growth, and if there isn't a soliciting cause as far as inflammation, sometimes the adenoids will regress, right? But not always. And I loved what Dr. Trey said today. Why are they inflamed? It was always binary for me. The tonsils are normal size or they're inflamed, right? The thought process to say, all right, well, hang on a minute, why are they inflamed? What can we do about that? I love that. So getting back to what we were saying before, we're going to look at these compromised airways that are from straight anatomic reasons. One of the ones that we are confronted with the most are Pierre-Robin sequence. It's called a sequence because it's a combination of an enlarged and malpositioned tongue this is usually felt to be the initiating cause, micrognathia, plus or minus cleft palate. So this is how they present clinically. There is a range. They don't obviously all look the same. They all look retrognathic, but the degree of which it affects them when they're born varies. Some children, they know this on the prenatal ultrasound. The team's prepared, they intubate right away. Everybody calms down, then they make the call. We come and see them, we figure out what we're going to do. But sometimes it's minor, and we just watch them. These are kind of the hard ones to figure out, honestly. The ones they call us and they're already intubated, we know what's going to happen. We're going to do an airway surgery. These kids, we tend to watch them. We talk about growth and development. We watch them over time to see what they might need. Lots of times, no surgical intervention at all. A lot of kids in that intermediate group, they're satting okay, they're sleeping okay, they're feeding okay, but also not. So what do we do with those? Those are kind of the tough ones. So we have grading scale to kind of go through and figure it out. We start to get into the 2s and 3s where we start to see pretty significant overjet between the maxilla and mandible. We're starting to get issues with feeding. If we do a sleep study, we'll see that pop up there. And then, plus usually we've got some combination of clefting as well. So either moderate impact to the neonatal management or severe, and we're going to look to operate. So that's pretty congested. I'm going to move on from there rather than put you through that. But this is kind of what we start to think. Supplemental oxygen, how to do with that. If they've got that level of issue with feeding or speech, they're going to have issues with feeding. So some form of ventral feeding is usually included. If it's severe, they'll get a G-tube as well. Or do they need more invasive and permanent management? So we start to look at this and we say, all right, can the child be sidelined? That's one of the things that's in the consult or in the note. One of the things we want to know is this whole thing relieved by tilting the child 45 degrees? And if it is, maybe we're not thinking in surgery or we're not thinking surgery imminently, right? It is or isn't. And as we kind of go through that, if repositioning is successful, then maybe it's airway management, right? They're not going to have oxygen cylinders at home probably, so they may not go home that way, but can we do anything to avoid surgery is kind of how we look at it in that group. If it gets to the point where we need to study their lower airway, and we've got the good fortune here, a little bit of hearing from a pediatric ENT who's very well respected in this area, and he'll kind of go into that. But that's also an evaluation that we want to know as well, right? We have our ENT, usually JAD, goes in, and they can do this in the NICU, and they evaluate the lower airway. The airway is in layers. We know we're ready to contribute to our part if it's at that level. But I want to know, hey, Dr. Jabbour, what do you see beyond that? Am I going to pull this baby's mandible forward only to find out that there's some glottic stenosis and we really didn't affect things? And then, of course, the option of tracheotomy is still present, fortunately not done quite as much as it used to be in these cases. So the first level of operative intervention and the least invasive is called tongue-lip adhesion. As the picture diagram shows and the name appropriately says, this simply is the minimal surgical dissection of the floor of the mouth and the lip. We pull that base of tongue up and over the alveolar process and connect it. So tongue, lip, really alveolar adhesion. Those are indwelling sutures that are non-resorbable, or at least most of them are, and we leave them anywhere from 8 to 12 months, and then they can be removed. So it's a good adjunctive technique for us, but the challenge is getting it right. Like, who are we going to use this for? How are we going to titrate this? In which part of that retrognathic patient population to know that we're going to hit the mark? This is not some step towards what is eventual mandibular advancement. We tend to know those when we see them. But this can be a good adjunct. So that's kind of what it looks surgically like. They're literally fused, but there can be a little tunnel preserved so that we don't get total adhesion to the alveolar process. And this is taken down in a pretty quick surgery. So this is an example. Of course, they're not happy about any of this, including getting their picture taken. But this picture kind of tells you what my practice sounds like most afternoons, right? Sound familiar, Mickey? You missed that? Yeah. Yeah. So the way it works is we've got a non-resorbable suture. This suture is tied here. It goes actually through the tissue, over the ridge, under the tongue, all the way to the base, circles back and gets tied. You can do it the other way, but whatever end has the knot needs a button or a bolster so it doesn't untie. We don't like to put those things in the airway for safety reasons, so they're on the outside. And then this is minus the milk here, but this is the after effect. So not a true permanent airway correction at all. It's a short-term measure. It's kind of a semi-permanent surgical hiking forward of the tongue to relieve that airway compression for a period of time. Part of the challenge, though, with it is sometimes you don't make that much of an impact. We see some success, particularly if you're applying it to one of the more severe cases and is really meant for one of the more mild interventions. So it has to kind of be used with caution. So now we're on to the category that I think really augments what's being said here. So I love the idea of everything that was said today. I hope that the pictures in the case I show you are few and far between, but when we need it, we need it. And so we thought to include that in our talk today. So this is an example of the findings that would put a patient, an infant, in need of the type of surgery that we described, where we do a surgical sectioning of the jaw. We put this device on. These days they're customized, and we start to crank that forward, and in the span of about 2 weeks we can bring these children forward 2 to 3 centimeters. And it's based on the principle that the bone will heal as we bring it along, as opposed to a definitive osteotomy where we open the gap, plate it, and it's kind of a sliding osteotomy, and we hope for bone fill. They're too small to do that, so we have to do a total transection. But what they figured out a while ago is if you move it at slow increments, the bone will heal as it goes along, and thereby create some stability as you go, and you just keep challenging it till you get the advancement you need, okay? So this is what they need to qualify. Severe obstructive sleep apnea, 18.5 on the AHI per hour while supine, and that is considered significant, and they have CO2 buildup as well. So fair warning if you're not medically or surgically inclined. We've got surgical pictures coming up. Can't really tell you the story without it, but some people might find it a little off-putting. It is after lunch, so we went ahead and put them in. But this is what these children look like, right? I mean, you can see right here, that's the position of his mandible. Yes, he is supine and relaxed, paralyzed, or not paralyzed, but relaxed under surgery. So of course he's going to be a little retrognathic, but that's their clinical presentation. And you can see the degree of mandibular retrognathy we're talking about. That's pretty significant. Again, mouth open position, but still in that significantly retrognathic state. So you can see the rotation now. There's audio on there, but you can see the rotation of that. And kind of tell you from a side view and a worm's eye view of what we're dealing with. This is a scroll through of the airway itself, and you can see at the center coming up right here, as you're tracing the breathing tube right here, but we get to this point where you're encountering the mandible, and look, there's no airway space around that tube. You know, the lumen of the tube is the only airway that this child has. So again, seen on prenatal ultrasound, prepared for, intubated immediately, they're safe. We don't like to leave them that way for too long, but it allows us the planning time we need to move through our protocol. So the way this works, we get that call, they're intubated, we see the patient. These aren't the in-between kids where we're positioning them and seeing these kids can't survive without that. In the old days, it was breathing tube until they get a trach and then they go home, and hopefully over time they can decannulate it and then they're done. Now we keep them intubated, we get medical grade CT, and we design, as you'll see, a custom distractor. Takes a couple of weeks, comes from overseas. So unfortunately they remain intubated that time, but they are safe, and then we go ahead and plan the surgery that we'll see. And the protocol looks like this. So we do our assessment and surgery. We activate the device intraoperatively to make sure it's working. Then latency period, some people challenge that. Mine is only about 24 hours, but it can be as long as 3 days in some protocol. Then we activate it, and we're doing a turn of typically 0.75 to 1 millimeter twice daily, so 2 millimeters a day. 10 days of turning, we've got these kids pretty far forward. Another 5 to 10 days, and they're really prognathic, and we try to overcorrect in this population. So I would say stop when it's improved, or just overcorrect and not even slightly. And then we let that sit, and those same devices become braces or plates, if you will, to allow that consolidation to fill in so the mandible becomes really rigid. Then it's back to surgery briefly, and we take that out. But if you look at the studies, going back on this, this was developed, I think some of the first papers on this came out in the early 90s. And that time, I mean, just really improvement, especially the more recent studies. I mean, really significant improvement. So, you know, a lot of tissue morbidity, but good success. So this is what the planning looks like. If anybody isn't accustomed to what's out there in terms of customization for hard tissue surgery, it's really pretty phenomenal. We can even develop cutting guides. So we do basically an inverted L osteotomy. If you're an orthodontist, you know those. We just do them on 2 or 3 week olds. Customized devices, we can trim all these tabs, and then the devices go percutaneous. So like I said, jaw surgery on an infant. This child's about 3 weeks old. After exposure of their angle of the ramus, we've got our customized cutting guide. Benefit of that is we're not kind of guessing, we're not malaligning things. The function of that custom designed device with the vectors that it predicts is dependent on it being attached to the mandible the way that the plan said. The carryover from the plan to the patient are these cutting guides and these predictive holes. So the same holes that screw the cutting guide into place are holes that hold the adapter. So it's very stepwise in these cases. And so that's the device on the outside of the patient. It is tunneled through. So the completion in this case, we've sort of sped up. We've done the osteotomy. You can actually see it here. I've got a video of it in action on the other side, and we tunnel it through to where it comes out. But this is very much what it looks like. Even if we have a sonopet or an oscillating saw, it's jaw surgery to create that cut. So we do the cuts before the device goes on, put the device on, complete the cut. That way there's stability before it goes on. So this is how they get activated. This stays like this, these little cardanic joints. This gets closed. Nurses and/or our team will come in and rotate that once a day. It cannot go backwards. There's a little lockout device. And that's an image you can see. Keep an eye on the osteotomy site here. As that rotates, you see the osteotomy spread, right? So what you're looking at is activation in the operating room to prove that the corticotomy, the osteotomy was done and complete. Then we back the device back down, wait in the latency period, and then move forward. But we prove that device is functional before we leave the operating room. We can make some really tremendous advancements. So this is just iodoform gauze. It's antibiotic. impregnated to keep the pin sites clean. We've closed the wounds. We always suture the tube because these kids are, obviously extreme airway risks, and premature or accidental extubation is kind of a nightmare. So take all those precautions, and that's how they go to the unit. But you can see after about 12 days of advancement, we want to see that really pointed chin point. And you can also see the joint, these cardanic joints, which start out pretty far out of the tissue, almost disappear as that soft tissue comes forward. So another evidence of how far forward they come. This is what the CT looks like. This is that picture before and after. You can see the amount of airway space. And remember that original CT, we repeat that at the end of the advancement. We always do that before we ever talk about extubating the patient or even think about sending him home. And that's what we want to see. So also under operative management, last case I want to show you has to do with this. And so those of you who treat cleft and craniofacial affected individuals know that they can kind of grow their way into being hypoplastic in the maxilla, right? So we track these kids through growth and development through our team. We're watching these kids maintain a relatively class 1 skeletal form, and some of this may be underlying class 3 tendencies. We don't know. But they do see frequently that they grow themselves into needing pretty aggressive, in some cases, maxillary surgery. So this is a young man that was referred to us actually from a clinic in another state. He lives in far western North Carolina. He was treated for unilateral clefting of the maxilla, but you can see, and you'll see more about the state of his maxilla. I mean, it's a little bit hard to understand how it ended up this way. I know lack of follow-up and burden of care was part of it. But here we are. So, significant issues with sleep study. That just stands to reason when your maxilla is that far back. So this is his initial study. Almost looks like he doesn't have one at all. It's there. It's just telescoped. As you'll see, misplaced teeth in the sinus and then the nasal cavity. No doubt prognathic in the mandible to begin with. But if you look at those numbers, 23 millimeters, 2.3 from any sort of vertical plane reference that you'd want to consider. There's a CT reconstruction, teeth imaged in the nose, total collapse. I mean, this is premolar touching premolar. That's the bird's eye view. So more than just a little hypoplastic, and that calls for a different set of techniques. And so one of the things that can be done is we can combine different layers of osteotomies to provide the change that we're looking for. It wouldn't have done a whole lot of good for this patient if we just took this portion and pulled it forward. In fact, what the challenge is sometimes if you picture taking 2 water glasses and you put the open ends together, right? That's a maxilla, it's hollow. You can take that top or bottom glass and pull it away from the top one, but only to a point, right? At some point, especially if they're small glasses, you've done a total disjunction of it. So you can take it to a certain point and then it starts to tip and get unstable. And so part of the idea was almost like a chest of drawers, bring the upper maxilla mid-face forward, the maxilla then forward further from that. So advance the base you're advancing it from to get more advancement is the idea. And so we talked to this young man and his family about stage treatment, but the first one requires that we have access to the upper skull and the mid-face. And so the access is like in our trauma case, it's bicoronal flap. That's his right orbital rim. There's the left to gain access to these structures. All those cuts have to be made in order to pull that forward. So I warned you, this is good stuff for after lunch, but this is osteotomy of the zygomatical frontal suture. That all has to be osteotomized and then verified. And you can see I'm demonstrating here mobility. We've got our Tessier forceps on the maxilla, and the maxilla and the midface are moving as one. So we do that, attach this device, looks very, very medieval. I'm seeing the attorneys in the room, you'd love to have a client that had this done to him, wouldn't you? Yeah.
I don't know, I couldn't watch those.
And through, this is distraction, okay? This is just distraction of the midface. So there's 2 wires that come from the body of the maxilla on the upper frame. The other 2 come from the maxilla itself, and so we've got that chest of drawers, okay? Lefort, combination Lefort 3 and kind of Lefort 1 advancement. So not a tremendous amount, but kind of looks like a different patient already, right? He's at least in the right zip code. And again, it's because we pulled the base forward before pulling this forward. And then right after that, we said, you've come a long way, but you need it, you need this another phase of surgery. So this is distraction now of just the maxilla, where we design these cuts, again, all custom, design how far we think we can move that. And if you compare that to his original mid-face position, this would have been completely disjointed. And so we took it in stages. So this is that young man now, still really, really far back. The final plan is actually not to put him in any kind of native occlusion in the maxilla. This will be implant supported in conjunction with needing to move his lower jaw back. So we're pulling out all the tricks to get him even close. Now, that's not class 1, but keep in mind, he doesn't have any anterior maxillary teeth. So before the orthodontist run me out of town because of that, we're having to imagine basically how it's going to finish. And by the way, Craig, he's going to come and see you. Did I tell you that part yet? Okay. This is going to end up in Craig's office. So beginning to end, or where we are now, we're going to go back, take the distractors off. He's on my schedule for a couple of weeks. Advance it the last little bit that we can, hold him there. Then the final phase will be extraction, bone graft implants. And Craig's going to drag it across the finish line. That's what I have. Thank you very much.